I'm going to talk about aortic stenosis, which is a center stage as far as the management is concerned, especially in the context of TAVI or TAVR, that it has gained importance. Before I talk about the echo evaluation of aortic stenosis, I'll just give you a couple of slides of epidemiology and what we see in aortic stenosis and what is happening here. Aortic stenosis, when we look at it, we find that as the age advances, we have the number of patients with calcific aortic stenosis which are going to increase. There are patients with congenital aortic stenosis and with rheumatic aortic stenosis, but a large majority of them are patients who have calcific aortic stenosis. They started as actually a sclerotic lesion, but they ultimately, over the years, they progress into aortic stenosis calcific. When we look at the prevalence of calcific aortic stenosis, we see that in these two studies, which are relatively old, you will see that as the age advances over 65, you have patients with aortic valve sclerosis. And in another study, where over the age of 85, you will find that the incidence increases even more. And calcific aortic stenosis incidence is 2% over the age of 65. And as the age advances, it is 4%. And as the lifespan is increasing, even in our part of the world, we are seeing more and more patients with aortic stenosis, which are then going to undergo either TAVI or aortic valve replacement. In the Helsinki study also, in the different age groups, you see the incidence of aortic valve sclerosis and calcific aortic stenosis. When we look at the prevalence of valvular heart disease, we will see that with the advancement in age, you get, here is the aortic valve which is involved, and then you have the mitral valve. Most of the mitral valves are in the form of mitral regurgitation. And then there is a mixed all-valve disease, which also includes the tricuspid valve, which is also involved as the age advances. The global burden that you see for example, in the year 2017, 12.6 million patients with calcific aortic valve disease, and out of these, 100,000 deaths because of aortic valve stenosis. And from 1990, as the age is advancing into 2017, there has been a doubling of the incidence of calcific aortic valve disease. It is more concentrated in the high-income countries as compared to the middle and the low-income countries. When we look at the natural history of aortic stenosis, there is a latent period, a progressive obstruction, and it is at this point that you will find that the onset of symptoms, when they come up, and you have a heart failure or syncope and angina, here then the incidence of sudden cardiac death in these individuals is increased. And therefore, we need to intervene much earlier before these symptoms come up. If you look at the natural history of severe symptomatic aortic stenosis versus outcome after aortic valve replacement, this is after the valve replacement, the survival that you have. But as in those cases where, for example, these 35 patients who refused surgery, you will find that these patients do not do well and they die over a period of time, and it is much earlier. When we look at the partner trials which were carried out, this is a kind of a natural history that you see in these patients. Those who undergo conservative treatment, they do not fare so well as compared to those who have intervention done. Then calcific aortic stenosis basically is an active process. There's a lipid infiltration, there's inflammation, and then calcification and ossification. We have the same risk factors for atherosclerosis which we have for aortic stenosis: hypercholesterolemia, Then you have diabetes, hypertension, hypertriglyceridemia, smoking. All these risk factors, LP small a, they actually increase the incidence of aortic stenosis. Now, no therapy or no conservative medical management has shown that you can reduce actually aortic stenosis in these patients. So this is a progressive disease, should be picked up early, and according to the symptoms, it should be intervened. So there's a high and a further increasing prevalence in the population over 65 years. Outcome of severe symptomatic aortic stenosis is very poor, and calcific aortic valve disease can easily be diagnosed at an early stage, AV sclerosis, and develops slowly. So far, no effective treatment is there to delay progression. When we look at I'm going to give you a case example here. An 87-year-old male, ischemic cardiomyopathy with an ejection fraction of 30%, CABG, diabetes, hypercholesterolemia, hypertension, peripheral vascular disease, COPD, not a very good kidney function, severe aortic stenosis, dyspnea 3/4, and angina. And this case was discussed in the heart team. 2D echocardiography is the technique of choice for the assessment, and this has been more so in the COVID era because most of the patients have been evaluated by echo. When we look at the LV dysfunction, which you can see here in this patient, and calcification, which is severe, and there is hardly any opening of the aortic valve, in such a situation it becomes difficult to evaluate these patients. And when we have the severe aortic stenosis criteria, it is the jet velocity, which is more than 4 meters per second, the mean gradient 40 to 50 millimeters of mercury, and aortic valve area less than 1 centimeter per square, and indexed according to the body mass index 0.6 centimeters square per meter square. That is the criteria for severe aortic stenosis. And this is normally the signal that you get when you do a CV continuous wave Doppler across the valve, and you get the maximum gradient, and according to the Bernoulli equation, you multiply it here with 4V square, and you get the maximum gradient. And as the gradient goes up, you find that the aortic valve area comes down. Now, how do we calculate the aortic valve area? I think what we need to do is get a CW signal across the aortic valve, get a VTI here, and also a VTI before the aortic valve. This is very important, the cross-sectional area of the left ventricular outflow tract, because it is this which actually determines sometimes the readings can become fallacious, and therefore you need to calculate the area just about 2 to 3 millimeters beyond the aortic valve. And this, since the aorta is more elliptical, it is not circular, so that is why you can have some problems here. So the calculation is extremely important of the cross-sectional area. Now, and you have to actually, if you look at the progression of the disease, you have to do it at the same place. Whenever you do it, it should not vary. The technicians or the doctors doing it for assessing the progression of aortic stenosis severity always measure the LVOT at the same position. This is extremely important. Now, what about planimetry? Can we do that? Is an alternative. If you have a good picture, you may be able to do it, but that is not what happens. More than 70% of patients do not have a good acoustic window for direct planimetry, and therefore what we now are doing, because patients who undergo TAVI, they also undergo a CT evaluation. And here you can see that in these patients, you can actually trace out the aortic valve area by planimetry in CT scan. So this makes it much easier to know the aortic valve area. But the difficult situation is when there is a low flow, low gradient situation. How do we actually measure the gradient there, and how do we get the aortic valve area, in which the aortic valve area may be severe, but the gradient is not so severe? That is what you see in a low flow, because the stroke volume cannot be generated so much because of the LV systolic dysfunction, and that results in the problems with these patients. So a large number of these patients, actually 35%, have depressed ejection fraction, a low flow and a low gradient. Let me show you a case here where a 73-year-old male with ischemic cardiomyopathy, ejection fraction 20%, comorbid conditions, progressive dyspnea, and this is the LV, which is so there's a systolic dysfunction here. You can see a calcified valve not opening so much, but the gradient is low here. So this is the low flow, low gradient aortic stenosis. The ejection fraction is less than 40%, and the aortic valve area is less than 1 centimeter square, and the gradient is less than 30 to 40 millimeters. In such a situation, is it the valve or is it the left ventricle which is responsible for this? And this is the algorithm which is followed here: a low flow, low gradient, severe aortic stenosis, aortic valve area less than 1 centimeter square. I'll quickly go through it. You can have either a pseudo-severe aortic stenosis, a true severe aortic stenosis, or an unchanged aortic valve area. In this case, we will do a dobutamine stress echo, in which case you will find that after the dobutamine echo, the gradient increases. So this was not the myocardium or the LV, it was the aortic valve which was severely stenosed with an area less than 0.6 centimeter in both the cases, pre and post dobutamine. So to find it out, this is a true severe aortic stenosis. Then most often you have those patients who have the aortic valve area unchanged even after dobutamine stress echo. In that situation, I think the calcium score becomes important. And for men, it is the upper, if it is beyond 2065, or in women, more than 1000, this is severe aortic stenosis. So you can do a calcium score and you'll get an assessment. The cutoff values are just an indication. Always use your clinical judgment. This is very important. And this is the last case here, where you have a female, 57 years old, atrial fibrillation. And this was the data here: current symptoms, severe dyspnea and persistent atrial fibrillation, the electrocardiogram, and once again on echo, an ejection fraction of 36%, a mean gradient of 14 millimeters, and a valve area of 0.57. Here again, with atrial fibrillation, it is a little difficult to calculate the gradient, and so you have to take an average of a number of readings. With dobutamine stress echo, you have a baseline, and on 20 micrograms, you find that the left ventricle is functioning all right. Now with this, you will have the gradient not so much changed, but the aortic valve area improves. So this is this situation where you have a pseudo-severe aortic stenosis. So dobutamine stress test and exercise test. If the patients do not have any symptoms, are pertinent in these patients who have the gradient may vary, and the aortic valve area also varies in these patients, but you then are able to find out about a true severe aortic stenosis and pseudo-severe aortic stenosis. And here, for example, you had the calcium score in this patient was low, and we were able to say that this patient has actually the aortic valve still opens after stress, dobutamine stress. So finally, in conclusions, aortic stenosis is severe when we have a jet velocity of 4 meters per second, a mean gradient of 40 to 50, a aortic valve area less than 1 centimeter square, and an aortic valve area indexed 0.6 centimeters square per meter square. The important thing is the low flow, low gradient. This was not important before, because when we were not doing TAVI, these patients actually were not accepted by the surgeon. But now with TAVI in place now, it becomes pertinent to find out these patients so that they can undergo TAVI, because that's a low risk procedure now. And then you can also do the calcium score in these patients, because invariably in those patients who undergo an echo evaluation for TAVI and then CT scan, you will be able to get the CT calcium score, and that will give you the indication how severe it is. So the numbers are important, but always trust your clinical judgment. Thank you for your patient listening.
Thank you, Dr. Shahbaz. Excellent talk. And I would request people to be interactive.
Shahbaz, we have the measurement of AS, the real matter is the measurement of LV outflow tract. Now, we have been measuring it just below 0.5 centimeter.
A bit louder, please.
Just 0.5 centimeter below aortic valve previously, then you said it is 2 to 3 millimeter. But the latest recommendation by the British Society of Echocardiography say that you measure it at the hinge point, where the aortic valve leaflets attach to the LV outflow tract aorta junction, not just exactly in the LV outflow tract. This is the latest recommendation. One thing, what's your take on that? Second, how do you incorporate LV strain in your recommendation for severe asymptomatic AS patients?
I think as far as the strain is concerned, it is very simple. You are doing left ventricular strain in these patients, and normally you'll find that in those patients who have had aortic stenosis for a longer period of time, they usually develop a reduction in their global longitudinal strain. And that actually also is an indication that you need to actually intervene before it is becoming irreversible, because fibrosis is there in these individuals when you have the global longitudinal strain coming down. So you will be doing surgery in these. Now it is being recommended that you do a global longitudinal strain, and it is being done more and more often.
I have a question, if I may. Yeah. Just had a question from the audience and the experts here in terms of how many of you guys are using PDOF probe for AS assessment. I mean, I don't have it on my machine. I don't routinely use it, but I've had a few patients where I actually underestimated the gradients because I could not really get parallel to the jet and parallel to the valve to get accurate velocity measurement. And you want to do it in different angles, different views to get the maximum velocity. The PDOF probe did make a difference and give us a more accurate gradient. And there was a paper done on that. This is how many in practice are using that probe and are comfortable with that in terms of having right parasternal window. And so sometimes you can get a much better gradient measurements on that.
I agree with you, but unfortunately, there are not many echo machines available with a standalone Doppler. And when we are looking at the gradient across the aortic valve, you need to actually assess it in the different windows at the apex on the right side and suprasternal, and where you get the maximum gradient, that is the one that you are going to then select in these patients. But
I would like to add a comment on this, that for PDOF probe, if you are getting velocity less than 3 meter, then it's okay. You can do with the mixed probe. But if you are getting a velocity more than 3, then PDOF probe is a must. And every dedicated echo lab must have a PDOF probe.
That's the issue. Most of our machines don't offer it, but I think that's a skill set that we all need to develop and should have the probe with most of our machines.
Independent
for accurate AS assessment.
Standalone probe is very good, and especially if you use it on the right parasternal border, you actually turn the patient over and then you use it. I have tried it even with a normal probe, and I am able to get sometimes, but I think it will be much better if you use a standalone.
It is very difficult, with a normal probe, but I guess Shahbaz sir does twist his ankles around to do it.
My take
but,
on
but the most important thing is that use all the windows and slide your transducer all along the chest. That is, don't get impatient with it.
My take on this is slightly different. I would like to see what is happening. PDOF probe is blind. So I would spend 5 more minutes with the patient. I am ready to do that. But when I see the jet coming, I have to align that. So I would turn the patient to the right side, do every possible window, and try to see the jet and then align the CW. PDOF is blind.
So there was a paper. There was a paper on it, And I don't remember exactly the year. I think it was 2016 or 17, and there was 26% reclassification by the use of pedov-proof.
It did
By the
make a lot
use
of
of?
difference with that, and they verified it.
By this pencil probe, there was the patient was labeled as moderate stenosis, but when they used the pedov-proof, it was about 26% patient turned out to have severe aortic stenosis.
What I feel is in the era of CT evaluation, it becomes much easier to do a CT scan in these individuals where you can also actually look at the cross section of the aorta. That is, you'll be able to find out the LVOT also in these individuals with a CT scan.
Dr. Shahbaz, Dr. Satish from India wants to ask you a question.
Satish, good morning.
Morning. No, I don't want to ask a question. I think there is a debate going on between the PDOF transducer and our normal transducers also. I think PDOF was used to be given free long time back because there's no charge for it. But I still feel that once it will take a lot of time to do with this. And I feel when you see a flow, then it is always better rather to doing a blind one also. In some cases, you may succeed, in some cases, you not succeed. And in any case, in elderly individuals, in a large number of cases, you may not get a good right parasternal view. So what we do, after putting a pillow on the right shoulder, we shift it and make a special right oblique view in these cases. And I would still prefer going for a usual color flow Doppler and rather than going for a blind probe also. This is my feeling also. I would just be happy. And when I get a case of aortic stenosis, I first start with a right parasternal view. If I get a right parasternal view with a nice flow, I'm very happy. Then I go to the other piece.
Thank you, Dr. Satish.
Satish actually is the father of echocardiography in India. And he has the most experience. And I agree with what he's saying that you can put actually a pillow under the right shoulder and then do the right parasternal view. It gives you a much better picture.